Good afternoon, ladies and gentlemen, and thank you for coming to People with Disabilities Foundation's 12th public seminar. My name is April Banerjee, and I'm the Program Manager for Public Awareness and Education at People with Disabilities Foundation. I am very pleased to serve as the MC for today's seminar, Overcoming Barriers to Physical Health Care Access. People with mental disabilities have shorter lifespans. People with Disabilities Foundation is a Section 501c3 public charity based in San Francisco. PWDF provides legal advocacy services for people with psychiatric and/or developmental disabilities in 8 Bay Area counties and public awareness events such as this one. In addition to seminars, we produce training videos for human resource directors, vocation rehabilitation counselors, and CDs on subjects such as employment and Social Security work incentive programs. Our advocacy program provides hands-on legal representation in Social Security cases and education, employment, healthcare, and housing as these areas relate to individuals' disabilities. In addition to this legal representation, once a month, we hold a Social Security disability insurance and supplemental security income post-entitlement and eligibility legal clinics, which address issues that come up after someone is already on benefits, such as overpayments, cessation, and work incentives. The mission of People with Disabilities Foundation is to provide education and advocacy for people with psychiatric and/or developmental disabilities, with or without physical disabilities, so that they can achieve equal opportunities in all aspects of life. I would like to take this opportunity to extend our gratitude to the speakers for taking their time out of their busy schedules and prepare for and be at this seminar, so thank you very much. Empirical data show that as a group, people with severe mental illness have significantly shorter lifespans than the general population. This shorter lifespan is primarily due to physical illness. Many factors have been identified as contributors to the increased rates of physical illness that lead to shorter lifespans. This seminar focuses on identifying barriers that people with mental disorders face when accessing physical health care services. More importantly, the speakers will suggest methods, health care service delivery models, and legal protections to help overcome those barriers. Please do ask questions and contribute to the dialogue following each speaker and during the roundtable discussion. Thank you for coming and for participating in this important discussion. I will now hand the microphone over to our moderator, Stephen Bruce.
Thank you, April. Today we're going to discuss a lot of evidence that relates severe mental and/or developmental illnesses to physical health care. Unfortunately, in most instances, the physical health care is not equal to those received by the general population. Some of the barriers, obstacles, or factors that we will be discussing involve lifestyle, mental health medication side effects, and some of the systemic factors involve separation of physical and mental health care and stigma. Stigma is defined as fear of mental and/or developmental illness. It is pervasive through society, including the health care profession, the legal care profession, other professions, and the general population. Other systemic factors include lack of funding for mental health care and cultural and language barriers, such as Chinese, or an individual who speaks Cantonese who may have trouble receiving mental health care by a psychiatrist who also speaks, for example, Cantonese. Provider issues, as I said, include stigma, writing off people's complaints as psychosomatic, not having the same resources and insurance companies not providing the same coverage. Until recently, it has been legal for insurance carriers to discriminate against coverage for mental disorders. As recently as the year 2000 in the Ninth Circuit, which covers this in other Western states, the 20th Century Fox case upheld the right of insurance carriers in healthcare to not provide equal healthcare services to those with mental health care needs. In 2008, Congress passed and the President signed the Parity in Mental Health Care Act, which says that healthcare providers and insurance carriers must provide equal health care. However, as is not unusual, the federal agency responsible for promulgating regulations has not finished implementing their final regulations. That agency is the United States Department of Health and Human Services. There are also patient issue factors in barrier existence, including lifestyle, substance abuse, exercise or lack thereof, diet, obesity, smoking, fear, including fears of going to the doctors, self-neglect, lack of motivation, and various difficulties in communicating either physical and or mental symptomatology. Generally, there is a lack of family or support and support of friends for those with severe mental and or developmental disabilities. Effective communication or not having effective communication as to both providers and consumers can also lead to a lot of difficulty in seeking gainful employment. Non-compliance with medical care, such as even not taking psychotropic medication, is another factor, and that's why we often see our clients or patients who get injections of Prolixin, for example, every few weeks. It's not because they prefer injections, it's because they don't take the pills in large numbers. We're going to, once having identified these and many other factors, go over how to remove barriers. Now, removing stigma, which is fear-based, is easy to say, but difficult to do. But different ways of doing it will be discussed. Co-locating physical medicine, including internists and psychiatrists, is another factor we look at in barrier removal. Delegating to psychiatrists those efforts that would normally be reserved for the physical health provider or internist brings up lots of issues, such as, does the psychiatrist have time? Do they have funding? Do they feel up to speed and competent to handle those kinds of physical ailments that are being addressed? The one-stop shops model, where you have mental health care and physical health care and housing all in the same location, have been shown to be highly successful. I believe they first started in Boston and San Diego many years ago and have now spread to many cities and counties in the United States. Training patients to be their own advocates and to communicate with healthcare providers, especially in diseases like diabetes and in other lifestyles, in addition to diet, such as physical exercise, are an important component of the different ways for barrier removal. It has also been shown that one way to effectuate better communication between psychiatrists and physical health providers is to require a form letter And this is a study out of Great Britain where the psychiatrist has one or two templates where they must put down the diagnosis, the kind of medication they are giving the patient, and what blood panels and other information they need. This letter is then received by the general practitioner or primary care provider, and although this model was at first unsuccessful, after audit, it has shown substantial and significant improvement and help in communication and integration of these two treatment modalities. This is a recent study from 2 years ago, and something as simple as required form letters actually can make a difference in the follow-up care of people who have been diagnosed and possibly treated with medications and/or psychotherapy. There are risk factors that are modifiable. Weight gain, the medications which cause metabolic system changes and weight gain can be changed. The dosage can be changed. Now, why is the risk of diabetes mellitus higher? Or why do people with mental and/or developmental impairments seem to have a higher incidence of diabetes? Is something that's unknown to me, as I've always thought that diabetes was genetic. But this is another area which the speakers will address, as we often see diabetes listed in studies. We will also delve into how we can prevent mental illness such as schizophrenia and depression, and go into other areas, just to mention a few, geographic distances between patients and physical or mental health providers is one other area that can result for the significant difference in lifestyle. I'm going to now turn the microphone over to our consumer advocates and ask Mr. Rob Chittenden from Disability Rights California to take the microphone. Thank you.
Hi, everybody. I think I'm going to pursue a little different perspective, and I'm going to talk a whole lot about stigma, discrimination, and how perceptions and language are quite important. Pam and I are going to share this PowerPoint, and the learning objectives are written up as you see. Explore the impact of stigma and discrimination on people with mental health disabilities. Discuss legal issues regarding access to physical health care for people with mental health disabilities, and develop strategies for reducing stigma and overcoming healthcare access barriers for people with mental health disabilities. Disability Rights California is an agency that works with people with all kinds of disabilities to help make sure that they're treated the way they should be treated. A lot of the agency, we have attorneys who answer legal questions. Also, they may do lawsuits. I work for the part of the agency that is called Peer Self-Advocacy, and we teach people how to advocate for themselves based on the peer model. All of us who work for the Peer Self-Advocacy program have had personal experience with the mental health treatment, and we help organize people into groups and talk about how to advocate for a whole lot of different things. Treatment, benefits, education, but we use our personal experience to help people learn from that and learn from their other people's personal experience. So that's what the peer model is about. You're welcome. Different cultural beliefs about people with mental health disabilities. On one side, certain cultures think that people with mental health disabilities are inspired, respected, just different. Other cultures may think that they're possessed, rejected, or abnormal. What is stigma? Attitudes and beliefs based on stereotypes that lead people to reject, avoid, or fear those they perceive as being different. You know, stereotypes can be harmful things. As a person who has witnessed people thinking that I have a tendency to be violent because of my experience, life experience, that I have no ability to think and take care of myself because of my past experience. So these stereotypes are things that are not true. Part of the stereotypes can be true, but to say everybody with a mental health diagnosis has the potential of really being violent or being helpless or not being able to think, these are really not true. And society at sometimes thinks that they are. What is discrimination? Discrimination on the other side is when people act on the stigma that deprives others their rights and life opportunities. Discrimination and stigma are based on the stereotypes that drive a wedge between us and them. There are three general types of stigma: public stigma, institutional stigma, and self-stigma. I'm going to talk about only one of these. I'm going to talk about self-stigma. Because I, from personal experience and experiences of others, it's when you kind of accept the attitudes of society or the medical community that these things are true. Self-stigma is rarely discussed and can lead to hopelessness and helplessness. I think people who have had a diagnosis work hard not to buy into this self-stigma, but it's hard. When you have around you people saying you don't have these capabilities. Language is really important. People may not think about language as being hurtful and stigmatizing. All these words up here stigmatize people, put them in a box. And sometimes, for myself, when I hear the word crazy, and it may not be used in the way in which other people might use it, I still think it shouldn't be used. On a personal level, effects of stigma can lead to low self-esteem, isolation, feeling devalued, social rejection, and shame. More effects of stigma: over-interpretation of behavior, opinions of the person are ignored, they're not given responsibility, not trusted, victims of violence, and barriers to seeking treatment. Many people say that the stigma associated with their own or their family members' diagnosis was more difficult to bear than the actual illness. Studies have shown that stigma is even prevalent among the mental health provider community. Knowledge about mental health disabilities does not prelude stereotyping. One study of mental health consumers and family members cited that stigma related to mental health care accounted for nearly 1/4 of their reported stigma experiences, and it comes from the California Strategic Plan on Reducing Mental Health Stigma and Discrimination. Yet people go to mental health professionals for help when they need treatment, understanding, and support. People who encounter stigmatizing attitudes from health professionals may avoid seeking or continuing treatment. Now I'm going to talk about two different approaches to treatment. One is the medical model, and one is the recovery model. And this comes from the client movement. And a lot of it has been accepted or tried out by the mental health community or treatment people. For the medical model, mental health assessments and diagnosis too often focus on weaknesses and problems rather than addressing a person's strength, interest, and goals. The recovery model talks about hope, personal empowerment, respect, social connections, and self-responsibility. I'm not going to read all of these. I'm just kind of talk about, in the recovery model, a diagnosis is a guide rather than a name for a person. In the medical model, it's a fact. In the recovery model, people have different realities that is not one reality. And in the medical model, it's people that lack insight into their own disability. In the recovery model, people choose what's best for them based on information, guidance, and support. In the medical model, they don't necessarily know what's best for them. In the recovery model, people with mental health disabilities can and do get better. Many times in the medical model, people with mental health disabilities can never truly recover. This is a quote from the Moods Disorders Society of Canada. Hope is one of the most valued ingredients in professional client relationships and the strongest predictor of positive outcomes. Once you choose hope, anything's possible. Actions that stigmatize: disrespecting, ignoring what people want, making decisions for people. How to reduce stigma and discrimination. Use plain language, language that everybody can understand. Use people-first language. Acknowledge and respect clients as people rather than disabilities. Treat the illness with the seriousness it deserves, but treat people with dignity and respect. Listen to what clients have to say. Empathize with them, but don't tell them what they feel or think. Identify, acknowledge, and explore a client's self-stigma. Health professionals are consultants who clients rely on for information, guidance, and support. I was on Medi-Cal for a while. And now I have private health insurance through my organization. Doctors say they don't treat people differently. They do. Also, sometimes physical healthcare professionals, when you go with a problem, think it's part of your symptom of mental illness. A woman just last week, we were talking about her going to her doctor, and she said, the doctor kept saying, this is part of your mental illness. And she kept trying to talk to the doctor, saying, no, this isn't. This is something else that's going on with me. So she had to go to another doctor and got a blood test and found out it was a thyroid problem. It was not what the doctor assumed was part of her mental health symptoms. So this is not uncommon, and it's a hard thing to have to go through. And I personally, see when you have private insurance, you get better treatment. And I can't believe that most of the people I know are on Medi-Cal, and they aren't getting the treatment that they should be getting. Be conscious of the power of diagnosis and the labeling process. This might also contribute to a wiser use of diagnosis. Focus on a person's strengths and what he or she can do. I'm promoting what I do: teach self-advocacy, help people help themselves. And here are 3 places people can go to get information. Peer Self-Advocacy Program of Disability Rights, California, the National Empowerment Center, the National Self-Help Clearinghouse. Both of the last 2 have a lot of good information that you can get for free and download from their websites. Thank you very much.
Thank you.
Yeah.
In my view, over many years of working with the population and with the Department of Public Health, people are getting mostly what you're talking about, but they're still stuck. So I think there's something more that we need to do, and I'm not sure, maybe you guys have all figured that out. I mean, I have my own ideas, but they're pretty extreme. So just, I hope some of you address that. So if they have this incredibly supportive professional group working with them, including psychiatrists, psychologists, doctors, where they're getting access to really good physical care, nurses in supportive hotels or in clinics who treat them with great respect and love, then I'm waiting to hear what's next. What are the other things that we need to be working on? Because I feel like I really want to become a bigger advocate. I've worked with disabled population my whole career, and then was a high school nurse, which has a lot of mental illness there too. So I just, what next? What do we need to be working on? Because this, obviously, but okay, so we get all these pieces in place. People are still stuck, and lots of us are stuck in something. Then what? Then what do we advocate for? Because they need a lot more coaching. maybe different environments, but hopefully you guys will get to that kind of stuff.
I'll just speak a minute about that, because it's something that changed my life significantly when I discovered self-help and discovered my peers. My peers said to me, "Why not?" When psychiatrists said, "Be careful." My peers were like, we'll walk with you. And why not try? You know, we'll be here to celebrate if you succeed. We'll be here to be with you if you don't. So I think people discovering people with lifestyle similarities can provide a life-altering experience. It did for me. When I discovered my peers, I discovered that I didn't have to kind of pay attention to what doctors had been telling me all of my life was, you know, just be careful. Don't overextend yourself. And my peers were like, you don't have to buy that. So you can try. Because I think, you know, a psychiatrist told me when I was 16 years old, don't count on having a regular life. And that affected me until my 40s. Until I met my peers, you know, encourage people. Hold the hope. You know, when I'm around people who are hopeless, I say to them, I'm going to hold your hope with me. So the peer experience, I think, is a wonderful thing.